Good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. And as some of you probably already know, my name is Leslie Rattan, and I'm pleased to be moderating our webinar series that's been developed for individuals that have suffered concussions, their caregivers, family, and healthcare providers. Our sessions have focused on various aspects of concussion and prolonged symptoms. And if you've been here before, you'll know that we start with an expert speaker for the first half of the session. And then that's followed by a question and answer period for the duration. And our sessions continue to recur every other week on Tuesday evenings, live from 6 to 7 p.m. So tonight is our 19th session, and you'll know that if you've missed any of the previous one, you can go to the Canadian Concussion Center website and find all of our previous webinars, which are there for you to review if you wish to do so. So for this evening, as per usual, you'll see at the bottom of your screen, there's a Q&A on the far right. So if you have any questions this evening, just enter them there. If you're having any technical difficulties, please enter those into the chat and someone will get back to assist you. And just before I introduce our speaker, just going to run a short poll that should appear on the screen. We're just trying to gather information on who our viewers are, just to help us better plan for future sessions. So you should see it up there now. And if you can just click, great. Thank you. So for this evening's session, I'm really pleased to introduce Leslie Birkett, who's going to be presenting Return to Work, Vocational Rehabilitation and Occupational Therapy. Leslie graduated from Queen's University in 1987, and she has worked for over 30 years in brain injury rehabilitation with both children and adults in settings ranging from acute care to the community. Leslie has operated her own private practice since 1995. In addition to her clinical work, Leslie is an adjunct assistant clinical professor in the McMaster University Faculty of Health Sciences Occupational Therapy Program in Hamilton. And she's also a hub member of the University Health Network's Project ECHO Concussion. Leslie is the co-author of the I CAN assessment, which is a community-based evaluation of executive functioning. And Leslie enjoys collaborative, community-based rehabilitation using a participate to learn approach. She thrives on situations that challenge her creativity and use of best practices and strives to assist her clients with meeting their personal life goals. And with that, I'm going to turn it over to Leslie.
Thank you. All right, I am going to share my screen. There we go. All right, well, I'd like to thank Leslie for that introduction and also the Canadian Concussion Center for asking me here tonight to talk to you about return to work following concussion. So as you know, my name is also Leslie, so easy to remember. And I'm really pleased to be here. So let's just dive in. All right, the learning objectives for today's session. By the end of this session, participants will be able to name the typical difficulties associated with return to work and describe ways to combat and/or accommodate the difficulties. So the first learning objective is to name the typical difficulties associated with return to work. And while the vast majority of individuals do return to work following concussion, studies do vary widely. In a 2018 meta-analysis of return to work following mild traumatic brain injury, the authors of the article cited on the slide found that 50% had returned to work 1 month after brain injury and 80% after 6 months. So this means, of course, that 20% had not returned to work half year post-concussion. In this study, the authors identified that the more complicated the neuropsychological profile, the more the return to work period is extended. So part of the reason the research varies widely and is so messy is based on the diagnosis of concussion used in the research, as well as the definition of work. Now, this sounds strange. However, the issue with the definition of work relates to what the study considered. So did they look at the person starting back to work? Did they look at the person returning to the same job? And also, how long did they follow subjects, as employment stability is of concern with this population? So there are a variety of factors related to employment status post-concussion, with different researchers focusing on different factors. And for example, in 2006, Nolan and Haru only looked at the initial symptom load, and they found that the total number of symptoms reported was related to vocational status. The variety of factors listed on the slide comes from a study by McAmmer and colleagues in 2005 that considered employment stability. And the authors found that injury severity was more predictive of the person returning to work, and factors relating to the nature of the pre-injury employment was more influential in the maintenance of employment over time. And we can see that these authors found the person's pre-injury employment status, the severity of their injury, their age, level of education, the injury-related physical impairments that they had that might have impacted their work, the cause of injury, the person's cognitive impairments, behavioral and emotional difficulties, comorbid psychiatric diagnoses, and environmental factors such as social and rehabilitation support were all associated with return to work. So I want to take a closer look at a few factors that have been studied. So mental fatigue, we know that fatigue is a common complaint following concussion, and certainly mental fatigue is a very common occurrence. And a group of Chinese researchers evaluated just over 100 individuals with a first traumatic brain injury who were more than 3 months post-injury. And they found two specific cognitive factors, recognition memory and processing speed, correlated with return to productivity. However, importantly, the results identified that these associations between recognition memory and information processing speed and productivity can be partially attributed to mental fatigue, even after adjusting for major covariates such as age and gender. So this is important to consider as a complete evaluation of fatigue and consideration of effective treatments for managing fatigue, such as looking at sleep hygiene, are recommended approaches for concussion management. All right, how about pain? Well, pain, including post-traumatic headache, are known to be linked to long-term outcome following TBI, with headache one of the most common symptoms following concussion. Additionally, post-traumatic headache has been shown to compromise cognitive functioning following concussion, which in turn then has been shown to predict return to work. So in a Canadian study of over 100 participants recruited from an outpatient center in British Columbia, the researcher found that headache was significantly associated with return to work, in that headache negatively affects return to work. And so again, we see another typical post-concussive symptom that has been linked to poorer outcome, specifically to return to work following concussion. And our messy, messy, messy theory remains proven. And as a reminder, you've heard previously in these Canadian Concussion Center webinars that treatment of symptoms is critically important to improve functioning, including return to work. So more generally, if we look at factors associated with poor functional outcome, the information on this slide is from the Ontario Neurotrauma Foundation, and we see factors related to poor outcome, including dizziness, the symptom load, post-traumatic stress, cognitive impairments, reduced social interaction compared to pre-injury, financial compensation seeking, loss of consciousness, pre-existing mental health difficulties, lower premorbid intelligence and cognitive ability, pre-injury work history, and cognitive difficulties. And all of these factors are associated with the poorer functional outcome. We can see here a significant overlap with the factors related to employment status that I previously mentioned. So the ONF, Ontario Neurotrauma Foundation guidelines, state to facilitate timely and effective return to work for patients with concussion or mild TBI, healthcare providers should use a structured approach to assessing fitness for duty, being cognizant of predictors and factors influencing outcomes of return to work. An accepted and effective approach to assess work readiness is for the healthcare provider to define risk, so those are the medical restrictions, define capacity, those are the limitations, and tolerance. So we've talked about factors related to outcome. And what about barriers to returning to work? Well, per the brain injury guideline, barriers include things like cognitive factors, So thinking, concentrating, understanding, remembering, planning, organizing, and multitasking, fatigue, persistent symptoms that might affect the person's ability to do their job, the invisibility of the injury, and lack of advice and guidance on return to work. So thinking about the cognitive barriers, let's take a glimpse at our current world of work. And let's look at typical skills necessary for jobs in today's world. The information on this slide is from job ads on ZipRecruiter. And we can see that employers are looking for individuals with excellent organizational skills and excellent communication skills, people who have the ability to multitask and collaborate or work well within a team setting, people who are able to demonstrate professional behavior with customers, the ability to manage a fast-paced work environment, the ability to learn, and self-motivation. So essentially, many higher-level cognitive and executive functioning skills are necessary to survive in today's work world, and this is why return to work is so tricky. So the BrainInjuryGuidelines.org identify that evaluation should focus on executive functioning, attention, memory, information processing, and verbal skills, as these were found to increase the likelihood of successful return to work. And we can see from these job ads why that makes sense. So the goal of the return to work plan for concussion is to enable the worker to fully participate in work tasks, so to maximize their work capacity, while remaining below symptom exacerbation thresholds. So to summarize, our first learning objective was to name the typical difficulties associated with return to work. And in a 2014 paper by Valjas, Iverson, and colleagues, they noted that the risk factors for poor outcome, and specifically delayed return to work after mild TBI, are diverse, complex, and not well understood. So we do have a ways to go. I don't want to finish there, as it's important to consider what helps. And what the literature points to is support from family, friends, and treatment team, as well as employers who provided accommodation. These are all noted to be beneficial factors. All right, so the second learning objective is to describe ways to combat and/or accommodate the difficulties. Why? Well, employment is an important determinant of health. And for workers, the literature demonstrates that brain injury patients who are employed report better health status, improved sense of well-being, greater social integration within the community, less usage of health services, and a better quality of life than those who are not employed. And when? Well, most people can begin the return to work process within the first few weeks post-injury. Workers with symptoms that are present but don't change with an increase in work or work-like activities can begin to transition back to work. And it's important to note that it's not necessary to be symptom-free to return to work. And if possible, in the specific situation for those individuals who are able to begin an early return to work, consider beginning with full-time hours with progressive duties to minimize workplace disruption and most rapidly rebuild the patient's routine. So current evidence indicates graded resumption of regular pre-injury activities is tolerated, so in a manner that does not result in a significant or prolonged exacerbation of symptoms, within the first few days to weeks post-injury should be encouraged, because regardless of a symptomatic status, activity is more likely to speed up rather than delay recovery. So I want to highlight some literature regarding the importance of early return to work. And as I stated earlier, the literature is quite inconsistent in terms of the length of time to return to work that's typical following concussion. The graph pictured is from the 2014 Valjas, Iverson, and colleagues study that I've previously mentioned. And they looked at Finnish patients, and they studied 109 patients. And one can see in this population a rather rapid return to work, with over 50% having returned within the first 2 weeks post-injury, and 94.5% returning by 11 weeks. The researchers noted significant differences in return to work rates in studies from different countries, and they noted that past researchers have reported that people who have expectations that their symptoms will resolve quickly actually have shorter recovery times. So this points to the important role of patient education from the immediate time of injury and ongoing. And I wanted to share another graph that's very similar to the previous one. It also highlights the importance of early return to work based on the number of people who returned after the 6 to 12 week mark. So we can see on this graph, the top line are the percent of patients who return to work. And the line on the bottom left is the probability that that person will return to work in the next week. And the line that goes diagonal across the graph is the probability of the person ever returning to work. So there is a short window of time to re-normalize life for the majority of individuals post-concussion. That being said, there's still hope for those who don't return in the initial period, as those are the individuals that occupational therapists typically work with. And from the brain injury guidelines, I just wanted to share this algorithm. So this is a decision-making tool regarding the return to work process, and this will be helpful for primary care providers. The guideline includes specific questions regarding the demands of the job, safety concerns, and suggestions for when to consider a vocational evaluation. So it is available on the website listed on the slide. And again, it's important to note that the existence of symptoms at baseline is not in and of itself a basis for no return to work. So prior to returning an individual to work, it's important to understand the worker's rights. In Canada, disability is a protected ground against discrimination and harassment. So with that in mind, and provided it's safe to do so, in most cases, the employer has a duty to provide reasonable job accommodation for the employee to the point of undue hardship. Specifically in Ontario, in general, legal protections for workers fall into 4 broad areas: fair treatment at work, protection of health and safety, duty to accommodate, and income replacement. And under the Canadian Human Rights Commission, an employer has the duty to accommodate. It's important to recognize that sometimes people need to be treated differently in order to be fair to them. And I'm sure this slide, or one like it, is familiar to many. It demonstrates the concept of equity as opposed to equality. So equity meaning that sometimes we might need to be given different things to be equal, and therefore alternative arrangements might need to be made to ensure the full participation of a person, including in their workplace. So what does the return to work process look like? Well, we want to aim for a gradual, progressive process. The Institute for Work and Health has published various resources on the topic of return to work. And I've found that their evidence-based practical resource actually aligns very closely with the process that I follow for those with prolonged symptoms. And this reference is available at the end of the presentation. So key points in their guideline include to develop an individualized return to work plan, to ensure communication with the workplace, to hold a return to work meeting with key stakeholders, to recognize that the return to work process may not be linear, and to maintain confidentiality. And so who might these stakeholders be? Well, of course, there's the worker, him or herself, and a coworker. I think it's important to identify who might be a source of support to the worker within their workplace. Of course, the manager is important to be involved in any return to work meeting because this person likely is going to assign work tasks and be in the position of evaluating the employee. Human resources can play an important role in any return to work meetings by clarifying company policies, and they may also be the direct liaison with the extended health carrier if that's required, and then possibly a union representative. And what's our role? Well, the healthcare professional identifies the medical restrictions, identifies the limitations, and we do want to think about physical, cognitive, psychosocial, and emotional limitations, and identifies and documents symptom triggers. So the employer, it's their role, based on the information provided by the healthcare provider, to review the specific job demands and determine the type of work that's available and whether the worker can be accommodated. So the employer and worker formulate the return to work plan. I do note, though, that I've often found that if the plan provided by the healthcare professional and worker is detailed enough, that the employer will accept it as it is. So now I want to talk about some of the specific terms that I've mentioned already. So restrictions. Restrictions are needed if there is a risk of harm that encompasses any situation where performance error in a physical or decision critical task could result in injury to the worker, co-workers, or the general public, and or disruption of equipment, production, or the environment. So again, we do want to consider physical, cognitive, and psycho-emotional status of the individual. And for example, someone with a balance impairment, we would identify that they're prohibited from working on ladders or at heights. And someone with impaired concentration, we might mention that there would be no operating heavy equipment and potentially no driving. And limitations. Well, limitations may not pose risk or harm to the patient or others per se, but they would reasonably interfere with the worker's ability to perform a given task. So they're therefore important to define to ensure that the worker is not expected to perform tasks that they're not currently capable of performing. So for example, with headaches, which again is a common symptom, to avoid heavy or repetitive lifting, to limit computer time, with irritability, to avoid customer service, with photophobia, to avoid brightly lit environments, and fluorescent lighting, which seems to be quite a trigger for many people, and to limit screen time. So the limitations are linked to the symptom triggers. So for example, headaches that are caused by excessive computer use. The headache would be the limitation, and the accommodation would be to decrease computer time, use an anti-glare screen, potentially to request an ergonomic evaluation of the computer workstation. I wanted to draw your attention to this reference for the best practice guidelines for the Ontario Neurotrauma Foundation regarding work limitations and restrictions. So again, if you need to reference that, that's there for you on their website. And what about the difference between graduated hours and graduated duties? So for primary care providers dealing with those individuals that are returning to work early post-injury, you will want to consider this differentiation. Ideally, you'll want to be able to review a copy of the person's job description in order to assist with the decision-making. So graduated hours versus graduated duties. Well, you must decide on a case-by-case basis. And in most cases, full-time hours with progressive duties are optimal because this provides the best opportunity for active rehabilitation. It rapidly reinstates the worker's routine. It helps to improve the person's self-esteem and minimizes workplace disruption, which in turn constrains psychosocial relationships in the workplace, which then pose new barriers to return to work. So what might that look like? It might look something like week 1, the person returns to work, working 2 hours of their regular duties and 6 hours modified. And week 2, they return for 4 hours of regular duties and 4 hours modified, etc. So it's important to remember to combine this with ongoing patient education regarding symptoms and expected positive outcomes. Well, what about those with prolonged symptoms? Well, there is a variable definition of this. Usually prolonged symptoms are considered greater than 12 weeks of symptoms, but more recently some consider greater than 4 weeks or 30 days. Now, estimates do vary. However, greater than 15% of individuals will go on to suffer prolonged symptoms. And these are the patients that I see as an occupational therapist. And return to work is still possible, and I've had patients return even after a year off the job. And for these patients, the return to work process can look quite different. When I develop a return to work plan, I always do so in conjunction with the worker, as they're the expert regarding their job duties. And if we're thorough and detailed, I do find that the workplace will typically accept the plan as written. And on the screen is a sample of the type of information that I include in any return to work plan. So for example, this individual suffers from fatigue. So we recommended a part-time graduated return to work. We noted that they may require intermittent work breaks between tasks and extra time for task completion. And we noted that both physical and cognitive activities might cause fatigue. I think that's important to note the cognitive activities because the general public may not be aware of that. We also recommended a private or quiet office space. This individual had some balance impairment, so they were restricted from climbing step stools and ladders within their office. They had difficulty tolerating bright lights and computer screens, so again, we recommended natural lighting and a desk lamp. We also identified that it should be a maximum of 1 hour of computer work followed by a change of task. For reduced attention, we recommended that the person complete one task at a time and avoid multitasking. We recommended that linear task assignments be provided with additional time for task completion. And we also recommended the ability for the person to work from home 1 day per week. So this plan was obviously done before COVID. And that may be one of the silver linings of COVID is that previously it was sometimes difficult to get a workplace to agree to the accommodation to work from home. But nowadays, for many workers, that will become an easy request. And so for this person, we recommended a part-time return. We started with returning to the office the week of May 3rd for 4 hours per day, 3 days per week for 4 weeks. We recommended a flexible work hours starting at 10 a.m. because sleep was still a bit of an issue, and reevaluation prior to a planned increase in hours. And that's really important to follow the worker along and try and evaluate before any changes in their work hours and shifts. And often with the patients that I see, I find that the increases in work hours might take 4 to 6 weeks initially and sometimes longer. And so the question that comes is, when do you increase your hours? Well, symptoms tend to increase with increased activity. So I look for symptoms returning to baseline before increasing work hours. So this needs to be a flexible and fluid process, similar to what was identified in the Institute for Work and Health document. And the person needs to be aware of his or her baseline level of symptoms before beginning the process. This means how long can they do a task before symptom exacerbation. So it is important to note that the specifics in the plan have been determined as best as possible through trial. So for example, the 1 hour of computer work was determined through a detailed history with the person trialing this at home. And I always attempt to mimic work tasks prior to returning to work. So for a secretary or anyone who needs to take minutes at a workplace meeting, you could have them try taking notes during the evening news. When I was returning a physician to work, we worked on them increasing their screen tolerance in a busy environment. So they did that in a coffee shop, just to mimic the environment that might occur in a hospital. So it's critical to ensure a planned follow-up with the worker in order to evaluate what's working, what's not working, and to make any necessary changes and adaptations. Well, what about accommodations? In a 2020 British retrospective analysis of over 170 patients with varying severities of TBI, so this was patients who had mild to severe, the researchers found that at 3 months post-TBI, 27.3% reported workplace accommodations. At 6 months, 27.9% were using accommodations. And at and at 12 months, I'm getting tangled in my numbers, 23.8% continued to have accommodations. So that's nearly a quarter of their population still had workplace accommodations 1 year post returning to work. And you can see on the slide there that the accommodations included a phased return, which would be a graduated return, more work breaks, a reduced workload, less responsibility, more supervision provided to the worker, the ability to work from home, and outside help. So that could be something such as a job coach, an occupational therapist, those types of things. So what this study noted was that the literature indicates that accommodations are temporary, and interventions to facilitate retention of return to work should be considered upon reentry to employment. Their findings indicated that support from employers may be necessary for longer periods following return to work after a brain injury. They hypothesized that this could be explained by the nature of brain injury not being understood initially, with sequelae, for example, poor concentration and fatigue, impacting productivity, and also noting that some of these symptoms may not be known for several months after work reentry. They stated that it's plausible that adjustments implemented initially may not be reviewed, raising questions about the importance of accommodations for job retention. They identified that future research must investigate the value of accommodations and establish how long these are reportedly used, or if they're in situ indefinitely. When we're thinking about return to work, it is important to consider the vicious cycle that you've been exposed to during these webinars. So essentially, when someone has a concussion, they experience symptoms, and these symptoms interact in a dynamic way. So for example, cognitive symptoms can cause the person to feel anxious, which leads to muscle tension. This in turn leads to physical symptoms such as pain, being a headache, which then causes decreased attention. And we have this cyclical pattern occurring. So to prepare the worker, it's really important to treat the symptoms and for therapists to consider a variety of strategies to help the worker. So as a therapist, I think it's important to review the use of strategies. You want to ensure that your client is using tried and true strategies and that the strategies have been practiced and are reviewed and tailored to the individual's work tasks. We do need to consider strategies for physical symptoms such as pain, headaches, and fatigue, strategies for cognitive symptoms such as attention, concentration, memory, and processing speed, and strategies for emotional symptoms such as anxiety and irritability. So what might some strategies be that are applicable to work? Well, we might have the person create a to-do list to keep on track of what they need to do for work. We might help them develop templates or flowcharts for complex work tasks. We might teach them how to use a mind map to break down a project. I often have workers write a list of the top 3 tasks to complete for their day, and sometimes I have them do it at the end of their work shift while they're still immersed in their work, so that the next day when they come in, they immediately know where to turn their attention. Sometimes I have workers set an appointment with themselves so that they have uninterrupted time, so that others are not phoning or attempting to reach them during that time. I think it's important to remember to get a good night's sleep, and so this is where we might review sleep hygiene. They might need to take task breaks, and I always tell people that no one monitors how often they go to the bathroom or if they take the long way to get there. I had one fellow whose office was on the 4th floor, and when he needed to go to the bathroom, he moved down 4 floors, across the lobby and up 4 floors to the bathroom right beside his office. And that gave him that nice movement break, got his blood flowing, and allowed him to get back to work. We might look at things like incorporating task changes, and sometimes that can even be a physical change that can help. Integrate energy boosters. We might want to think about implementing deep breathing or mindfulness techniques for stress and anxiety related to work and work tasks. We might want to recommend an ergonomic evaluation of the work environment. We want to always be prepared because, as one of my clients said, failing to plan is planning to fail. So sometimes clients start preparing for their work day the night before, and this might be new for them to get organized the evening prior to work. And for metacognition or executive functioning, training of formal problem-solving strategies and their application to work tasks is identified in the literature as beneficial. And of course, those are those high-level cognitive skills that are so critical in complex, novel tasks. So it's important to follow up and discuss specific work tasks that are proving to be challenging to the worker, and then to develop and apply specific strategies. So I wanted to highlight this best practice resource from the Ontario Neurotrauma Foundation. So this is for individuals who are considering returning to work following a concussion, and it provides some general ideas to consider regarding return to work, some information about symptoms at work, and how restrictions and accommodations might work, and it does provide some additional resources. I also wanted to showcase this resource out of British Columbia. It contains some simple and practical resources. So for example, you can see on the right side of the screen, this guideline for progressing tolerances to support return to work. And their website actually has lots of really useful and practical information on it. And what about teens? Well, for any of you who have a teen or have worked with a teen, you'll know that, of course, many teens are very focused on money, money, money. For children, for teens, we really want to highlight that the return to work should be after the child has returned to school, because returning to school is their main job. So we look at following a successful return to school, and that means with a full course load and no accommodations. Then we could look at return to work. And the teen may need help prioritizing to look at, do they look at return to work or return to sport first, which is the most higher priority for them. And again, it's important to note that we may need to advocate with the employer and consider job modifications. So finally, we would be remiss without considering those individuals for whom return to work is not possible. So when persistent post-concussive symptoms impede return to pre-injury employment, educational activities, community roles, and activities that promote community integration, such as volunteer work, may be considered as an alternative focus for meaningful activities. And so wrapping it up, work has many benefits for the individual. The goal of the return to work plan is for the worker to fully participate in work tasks while remaining below symptom exacerbation levels. Return to work plans must be specific and include restrictions, limitations, and tolerances. Complex cases may require a vocational evaluation. And if symptoms preclude return to work, consider an alternative focus for meaningful activities. And finally, there are a list of resources for you. All right, I'm going to stop sharing my screen now. There we go. Thank you for your attention.
Great. Thanks so much, Leslie. That was great. A lot of really helpful information. I'm going to go. We've got a few questions already on the go here. So Danielle is asking if you can answer this question. It is about getting into a brand new field of work that would accommodate concussion symptoms. Are there places that would help evaluate employment possibilities that are ABI friendly? If so, are there places that would evaluate the education and aptitudes required to acquire these ABI or acquired brain injury friendly jobs?
So that's a really good question. And that would be the purpose of the vocational evaluation. So typically in a vocational evaluation, the evaluator looks at aptitudes, interests, skills, abilities, and also when we're talking post-concussion, looks at any ongoing sequelae. And so that is a great resource to help someone if they're looking at making a change.
Great, thank you.
Mhm.
We have a question, and I think this harkens back to when you were talking about attention and recommendations. Can you please share examples of linear task assignments and how they might help with attention challenges?
Mm. Yeah, so that's another good question. So, of course, in today's work environment, many, depending on the person's job, there are many tasks that are complex and have multiple different phases going on at once. So, in particular, for this individual, we were looking at a situation where these complex tasks would be broken down, and it was a process of completing step one before moving on to step two. Part of this, in this instance, as an example, was looking at some sort of policy development in the workplace, which of course can spin off in many different directions. So the point of that was because of the attentional difficulties for this individual, if they were moving back and forth between different aspects of the task, it was very hard for them to remain on task. So it was easier to focus on one aspect and at completion then move on to the next. So I hope that answers.
Great, thank you.
Mhm.
April asks, I am 2 years post-concussion, did a gradual return to work throughout the pandemic and doing well at home with the following accommodations: an iris computer monitor, a printer, and max 30 minutes of video conferencing. We will be finally returning to the office where I have my own office, so I'm not concerned about noise.
Mm.
What additional accommodations would you recommend? My main concern returning is the fluorescent lighting.
Right. And so, yeah, thank you. So fluorescent lighting is a tricky one. I have had many, many people who have requested no fluorescent lights in their office. And typically that is able to be accommodated. I mean, I am not an electrician. I know almost nothing about electrical work, but what I have learned is that it sort of depends on how the electrical work is set up and whether it's continuous throughout the office. But typically I've had workers where, and particularly you mentioned you've got your own office, they can then either change the lighting in the office or just not use the fluorescent lighting and instead use lamps. And I've had many workers do that, particularly if they have a window and they can access natural light, which seems to be pretty concussion friendly. Then they just bring in lights, and depending on the workplace, they have to have them approved by health and safety. And then they would use desk lamps and floor lamps of their own choosing.
Great, thank you.
Mhm.
I think we have another Leslie who says, I'm a retired person with ongoing concussion and PTSD, currently at 1.25 years. So I'm assuming that's 1.25 years out from the concussion. I used to manage on a daily basis financial investment portfolios for myself, other family members, and provide consultation to friends. Since the injury, I cannot functionally do this work due to many symptoms. Any suggestions? Does an OT have access to bring in a chartered financial analyst to observe the missing equations and overseeing the missing links?
So that's a really good question in a difficult situation. So I wouldn't necessarily say that an OT has access to a financial person to do that. I have at times brought in brought in individuals for that exact reason to do some supervision. So for example, with a welder, I did bring in a welder who was able to give some knowledge about the specific processes and help with safety checks. But that, in that specific instance, was organized through the worker. So you may find an OT who has access to an individual who has that skill set, but sometimes you may be able to link someone that you know in the industry who has the skill set that you're looking for with the therapist to help bring those two together to look at where the gaps are, and maybe if there's some structure and supports that could be put in place to help.
Great, thanks very much.
Mm-hmm.
Okay, next question. Would your return to work recommendations and strategies change if the person has had a previous unsuccessful return to work attempt?
So I am assuming, I think, or we're talking about the same job, going back to the same job. So if that's the case and the person unsuccessfully went back, I think it's very hard to answer without knowing more details. I have had situations where I've had individuals and they have had an unsuccessful return to work. And sometimes it was the speed of the return to work process that didn't work for that individual. It wasn't necessarily other job accommodations. So I think you need to try and sort of drill down and figure out where did the return to work process break down in order to then decide, do we need different strategies? What is that going to look like? So I hope that's helpful.
Okay, thank you.
Mm-hmm.
Nadine asks, what are the best strategies for combating computer screen fatigue?
That is a very tricky one. And I think, again, it's different for different individuals, although it is very common. So we have things like reducing the amount of screen time, changing a task, so moving from a screen to something else. Some people find filters are very helpful, different screens, different lighting. I've actually had some clients who, because of some visual difficulties, they find that either a larger or a smaller screen helps. So I think sometimes it is a little bit of trial and error depending on the person.
Great, thank you. Mark asks, I've been off work for 6.5 years with one failed to return to work 7 years ago. How will I know if I am ready to go back to work?
Oh, that's a hard situation, Mark. I think the best thing that you can do in that situation is look at that piece that I spoke about looking at your tolerance for work or work-like activities. And so that would be figuring out what kinds of work activities you had, how can you mimic them at home, and seeing what your tolerance is to do that. And to do that, you really have to carefully take a look. I have some people who say, well, I think I can do about 2 hours, but it doesn't really give you the information that you need. So I tell people to try actually tracking it and try it, on a day-to-day basis. I was able to do 1 hour or 1.5 hours or whatever it is, and use that information then to see if you can build up an acceptable level, which will be different for different workplaces, of tolerance to allow you then to try. I started working a long time ago with a woman who had a very, very, she had had a previous unsuccessful return to work before I met her. And it turned out she was working a very, very few hours per week, less than 5. And so really, I can understand why that didn't work. It's also very difficult to be productive over 5 hours spread over the course of a week. So we really looked at trying to build up enough tolerance on a given day so that she could do 2 or 3 or whatever her workplace required per day before trying to return to work.
Okay, thank you. Dr. Tatter is asking, why do you prefer starting at full-time for concussion patients? So returning to work full-time and wanting to know, does it ever work?
So that is for the individuals who are returning in the short term versus the individuals with prolonged symptoms. I can say that for individuals with prolonged symptoms who I've worked with, I've never had someone return with full-time hours. So for the immediate post-concussive period, if you look at those graphs, certainly it would show you that you do want to get people back quickly, and that depending on the job, if the job can figure a way to do the regular duties and accommodated duties, then it can work. And for the reasons that I highlighted in terms of minimizing workplace disruption, et cetera, that in itself, with the worker being back at work, provides that active rehabilitation for them.
Great, thank you.
Welcome.
Sorry, I was just looking at the chat. There was a little bit of back and forth that I think everyone can see. Chitra is saying, still I have a headache on continuous monitor noise and unable to concentrate. Taking some time out. It sounds like she was diagnosed with a concussion in 2016, sleep issues ongoing. She's an ER nurse and expected to do rotating shifts, has migraine headaches with aura present. So it sounds like she's perhaps struggling with work subsequent to this concussion, which was now almost 6 years ago, I guess. Any thoughts on that, Leslie?
Yeah, that is so tricky. And one of the things that I've done when I have had healthcare providers is I've advocated that they actually not return to work doing shift work if sleep is a problem. I think that is so difficult to try and navigate. So I have successfully been able to advocate in the past for those types of individuals to return working on regular daytime shifts until their tolerance builds up and they're able to tolerate full-time hours. And then I have had some successfully transition back to shifts, and some I've been able to return to work full-time but not transition back to shifts. So that has been an accommodation that we have looked at, avoiding the shifts. And I think that's pretty important for someone, as I said, with any kind of sleep disruption.
Mm-hmm. Dr. Tatter was just following up. He's asking, do you go to speak to the workplace manager?
So when I'm setting up, thanks for the question, a workplace meeting, I always ask the worker to initiate the call to the workplace. And I say that I feel that if I'm working with someone and they're ready to return to work, the last thing you want is your occupational therapist calling for you. You want the worker to be in the driver's seat. And so I ask them to call whoever's appropriate at their workplace, they would know, and tell them that they're interested in setting up a return to work meeting and bringing part of the rehabilitation team, whoever that might be, and asking the workplace who they would like involved. So I've seen all kinds of different configurations over the years, but managers are often involved, yes, at those meetings. But again, up to the worker and the workplace to determine.
Great, thank you. Interesting question. How do you suggest people handle interpersonal relationships at work because of emotional difficulties? So things like that happen post-concussion, getting angry easily, temper issues.
That's a great question. Leslie, do you want to take a stab at that first?
Well, you go ahead, Leslie, and yeah.
Okay. Yeah, I think that's a really difficult one, of course. And, particularly if the individual is returning to, a work environment where their maybe weren't the most collegial relationships initially. Or I was recently working with an individual on a call center and she was pretty irritable. So that was tricky also, because we had some complaints with management of calls as they came in. So typically if someone is really struggling with those, I always recommend, if they can, work with psychologists, that would be a great thing to do to find some strategies. And ideally before they return to work, although, sometimes that doesn't happen. But I think it's really important to try and, figure out what the triggers are and what are the ways that you can manage those situations. People are often really reticent. They don't want to share this information with all their colleagues. And I think that's very understandable. But if they're having outbursts in the workplace, the colleagues are going to find out that something's going on. So it's better to be proactive and try and get some support and strategies before returning to work. So that's sort of typically my approach. I don't know, Leslie, if you have anything to add to that.
No, I don't think so. But I would just agree that you really want to try and, ideally, if you can be working on those things prior to going back, and then ongoing, I think having someone while you're transitioning into the workplace so that they're able to work with, whether it's a psychologist or other mental healthcare professional, to actually kind of deal with those issues as they're coming up as well. So Anne asks, she says, my employer only accepts accelerated return to work plans over 6 weeks, and they do not allow me to remove any of my duties. Can this be contested?
That's an excellent question. That sounds to me like a question for an employment lawyer. And when I do get questions like that from some people I'm working with, I do suggest that they contact a lawyer. Most lawyers will do, a one-time phone call without charge to provide some advice. And if they need to get involved, then of course that would change. But that to me sounds like something that should be addressed through a legal consult, I would think.
Great, thank you. Marie asks, she says, my motor vehicle accident, brain injury resulted in my inability to do math. Could an OT order tutoring from a company like Sylvan, for example, and have it covered by my car accident insurer? Would a phone app that helps with pacing be paid for?
So, good question. I definitely have seen tutoring paid for. And I definitely have seen phone apps paid for. So I think there are possibilities. I think always any recommendations need to be well justified and need to be sort of thought out carefully and made sure that there's the possibility that it's going to get you where you want to go. But yes, I have seen those types of accommodations and supports paid for.
Great, thank you. If a person is unable to return to work, how do you help the person evaluate their capacity if they wish to get involved in volunteer activities?
That's a good question. Well, one of the things I always say about volunteer work is one of the great pleasures about it is that if you can't go to your shift, you don't have to go to your shift. So I think for most people, it's finding out what they're most interested in. And then looking at, and many communities have, for example, I live in Halton, the region of Halton has a database of open volunteer possibilities, and sort of looking through there and seeing what's available, and then contacting the facility to find out more details about what is possible. So that might include how long are the shifts, what happens if you show up and you can't work that length of shift. How often do they want people to volunteer? Some places really only want people once a week. Some people want them multiple times. So finding out all those details, and then if it seems like it's a fit, then signing up for whatever orientation they have and proceeding at that point.
Great, thank you. Waman asks, it says, I've been off work 6 months. However, my employer terminated my position before I was supposed to return to work. I'm trying to replicate a gradual return to work at home through increased screen time, cognitive tasks, etc. Do you foresee any issues if I try to return to work full-time in about 4 to 5 months as I search for a new job?
Oh, I'm sorry to hear that. So I think it's difficult for me to foretell the future. I think the best thing that you can do is to do what you're doing and continue to work on your work tolerances as best you can, work on your screen tolerances. And in 4 to 5 months, if that's the time frame that you're looking at, see where you're at. And I think it's really important to really be honest with yourself. If what you're capable of that time, for example, is part-time, then looking for a part-time position. Because when I have worked with people who have then gone and looked for a full-time position and not been able to manage it, that leads to many more difficulties and problems. And it's really an untenable situation. So particularly in a new job where there's lots of new learning, and that can be a real challenge, you want to make sure that your tolerances support the hours that you plan to be working.
Great. This indicates, I have a client who returned to work prior to OT sessions and is very hesitant to discuss their concussion symptoms with their employer or modify their duties. Do you have any suggestions on how to approach this?
Yeah, that's a really difficult question. And I've had the same thing happen. Sometimes with me successfully intervening, sometimes not. I think the one thing which sometimes is helpful is, helping the person understand that if they're having difficulties and challenges in the workplace, the risk they take by not disclosing is that it becomes a workplace performance issue. So without accommodations, then the employer has no way of knowing that the person is dealing with any specific health issues. And then if the person makes mistakes, and I have had this happen, they may have repercussions or be terminated. And so sometimes having that really frank discussion that, this is there to help you, because then if you have accommodations and the accommodations identify, which is what they should, the specific issues you're having, then the workplace really is in a different position. So I think it's a difficult conversation, but I have been able to help people understand that we really don't want it to lead to a workplace performance issue, because ultimately that is going to be much more difficult for them.
Great. And what if Nadine is asking, what if you're having trouble gaining employment in an industry you're interested in?
Yes, I think that's been a common theme during COVID. So I'm not exactly sure. I'm not exactly sure about the question. Can you help me out with that?
Nadine, if you can add anything to that. It sounds like you're having trouble. It sounds like maybe this is something that you haven't done before and it's new. Maybe Nadine, I see that we're almost out of time. So, oh, yes, she said. Oh, should she consider a vocational assessment? Thanks, Nadine.
So sorry, should she consider a vocational assessment if?
Yeah, so Nadine, can you give us just a little bit more information? It sounds like you've had a concussion and you're looking into a new area of work and you're having difficulty kind of breaking into it. Yes. Okay. Yeah, having trouble gaining employment in a new area of work.
So I don't know necessarily that a vocational assessment would be ideal in that situation if you've already determined, where you'd like to work. So that's great that you have some thoughts there. I think in this case, there are individuals out there who help with things like resume building, job search skills, and interview skills. And it might be that you want to look more for someone like that sort of job coaching individual to help you with those skills. That sounds like that might be more helpful to you.
Great. Yes. Thank you. Okay. I think we've got one more in the questions. So I think they're asking in both. During work, when is the best time to take a break? Is it best to take a break once your symptoms have developed or to do it preemptively?
Yeah, that's a really good question. I always, if it's possible, think it's better to take the break before the symptoms develop, because we're trying to avoid symptom exacerbation. And so if you can take a break, and again, a break doesn't mean having your feet up and having bonbons. It might mean, changing tasks if that's possible, et cetera, et cetera. But it's ideal to do that before symptom exacerbation, because you're trying to avoid the symptoms exacerbating. So if you can feel a headache coming on and you can take a break at that point rather than waiting until you have the headache, that would be more advantageous for you if you can work that into your work schedule.
Great. Okay. Thank you so much, Leslie. I think we're pretty much at time, and this worked out quite well because I think we got to all of the questions. So thank you again. Really appreciate your time, and thank you everyone for attending. Just a reminder, you will get a short survey. It is very short, and we'd really appreciate it if you took a minute or two just to fill that out and give us your feedback and any suggestions. And finally, just a note that our next session will be in 2 weeks tonight on March 1st, and that will feature Dr. Michael Hutchinson and Dr. Richard Wenberg, and they're going to be speaking about return to athletics, principles, and who to see. So thanks again. I hope everyone has a great evening.